Bismillahirrahmanirrahim. Quote of the day is, "We created you, then why do you not acknowledge it?" This is the ayah from Quran. My name is Dr. Aamna Khalid. I'm PGR Community Medicine. Today I will be presenting the topic of minerals, which will include magnesium, iron, iodine, and fluoride. I'm doing this presentation under the kind supervision of Professor Dr. Saira Afsal, who is Dean, Institute of Public Health. Learning objectives of these presentations will be burden and public health importance globally and national as well, daily requirements of each of the mineral, key physiological functions, clinical features of deficiencies, diagnosis, management, levels of prevention, WHO recommendations, and program indicators for monitoring. First of all, we will go through magnesium. Magnesium is the second most abundant intracellular cation after potassium. 60% of it is found in bones, 39% in soft tissues, and 1% in serum. It plays a central role in more than 300 enzyme systems. Its deficiency is often masked in serum despite the intracellular depletion is there. High prevalence of magnesium is found in malnourished state, in alcohol dependence, diabetes, chronic diarrhea, use of proton pump inhibitors and diuretics, hospitalized or ICU patients, and the deficiency often coexist with hypocalcemia and hypokalemia, so worsening the outcomes. These are the dietary sources of magnesium. There is a wide range which includes the vegetables like spinach, kale, Swiss, pumpkin, chia seeds, sesame, flax seeds, almonds, peanuts, lentils, legumes, and cereals like wheat, brown rice, oats, salmon, and milk, yogurt, eggs. But the water mineral content varies regionally. These are the WHO recommendations of daily use of magnesium. So an adult male should have 400 to 420 milligram of magnesium per day. Adult female 310 to 320 milligram per day. In pregnancy, it increases to 350 to 360 milligram per day. And in lactation, it's 310 to 360 milligram per day. Children from 1 to 3 years, 80 milligram per day. 4 to 8 years, 130 milligram per day. And 3 to 19 years, 240 milligram per day. These are the major functions of magnesium: ATP synthesis and stabilization, neuromuscular conduction, cardiac rhythm regulation, bone mineralization through calcium and vitamin D metabolism, insulin signaling, DNA, RNA, and protein synthesis, sodium, potassium, calcium, iron transport regulation. These are the clinical features of deficiency of magnesium, which starts from anorexia, nausea, fatigue, muscle cramps, and then comes the tremors, seizures, refractory hypokalemia, and hypocalcemia. The cardiac symptoms include ventricular arrhythmias, prolonged QT, torsades risk, and the mental health problems include depression and irritability. The diagnosis of magnesium is made when the serum magnesium level is less than 1.7 milligram per deciliter, and there are changes on the ECG, which includes prolonged QT. There is associated hypokalemia and hypocalcemia, and clinical neuromuscular irritability is present in the patient. We manage magnesium on the basis of its level of severity. Mild to moderate hypomagnesemia is managed orally by giving magnesium oxide 240 to 480 milligram per day, or magnesium chloride 300 to 600 milligram per day. If the patient has symptoms and the condition is severe, we have to give IV magnesium sulfate 1 to 2 gram over 1 hour, and we have to repeat it to maintain the levels. In case of arrhythmias, it's an emergency. We have to give 2 grams of IV over 10 to 15 minutes. And we always have to correct potassium and calcium levels simultaneously. So now we come to the prevention. The primary prevention includes we have to promote magnesium-rich diets. Rational use of diuretics and PPI should be there. Reduce alcohol misuse, And nutrition education should be done through the IEC approach. So the secondary prevention includes screening. Screening should be done in the diabetics, alcohol-dependent patients, chronic diarrhea, and ICU patients. Sentinel surveillance can be done in the clinical settings. Magnesium tertiary prevention involves the treatment of complications like arrhythmias, seizures, tetany. Rehabilitation and nutritional recovery should be done. Uh, Excess of magnesium is also symptomatic, including hypotension, respiratory depression, bradycardia, lethargy, and risk increases in renal impairment. Now we come to iron. Iron is the essential trace element for hemoglobin. It's also important for myoglobin and multiple redox enzymes. The deficiency of iron progresses from depletion, then impaired erythropoiesis, and which leads to iron deficiency anemia. So it's the most common nutritional deficiency worldwide and major contributor to maternal and child morbidity, poor cognition, reduced work capacity, infection susceptibility, preterm birth, and LBW are caused by iron deficiency. These are the dietary sources of iron. Iron exists in two forms: the heme iron, that is got from red meat, liver, poultry, fish, better absorbed from these sources. And non-heme iron is obtained from spinach, legumes, fortified cereals. Some things are there which enhance its absorption, including vitamin C and wheat proteins, and a few things inhibit its absorption, which includes tea, coffee, phytates, calcium when they are ingested. These are the daily requirements of iron as recommended by WHO. The adult male should take 8 milligram per day, adult female 18 milligram per day. In pregnancy, it's 27 milligram per day. And children should receive 11 milligram per day from 7 to 12 months, and then 1 to 3 years 7 milligram, 4 to 8 years 10 milligram, 9 to 13 years 8 milligram, and adolescents 14 to 18. Boys should have 11 milligram and girls 15 milligram per day. These are the major functions of iron, including oxygen transport, um, muscle oxygen storage, anti-enzymes for cellular respiration, immune cell proliferation, neurodevelopment, and cognition. These are the range of clinical features of deficiency of iron, ranging from pallor, fatigue, breathlessness, tachycardia, pica, koilonychia, glossitis, angular cheilitis, poor attention and cognitive performance in children. All of these are due to the iron deficiency, leading to anemia. So the diagnosis is done on the basis of some laboratory test along with the clinical symptoms discussed before. So on the CBC, there will be decreased hemoglobin. Serum ferritin is low and it's the earliest marker. Transferrin saturation will be low. On peripheral blood smear, microcytic hypochromic RBCs will be there. And population anemia surveillance can be done via HB screening. So we have to manage the iron deficiency in children 6 to 59 months. We have to give elemental iron 3 milligram per kg per day for 3 months. In adults, we have to give 60 to 120 milligram per day elemental iron for 3 months. In pregnancy, the dose is 60 milligram iron along with 400 microgram folic acid. If severe anemia is dealt with blood transfusions, then iron correction is done. Deworming adjunct with albendazole or mebendazole, and the dose depends on age. So now we come to the prevention. The primary prevention involves iron-rich diets, large-scale food fortification, and iron folic acid supplementation. Secondary prevention involves HB screening in pregnancy and school health surveillance. Tertiary prevention involves the treatment of anemia once it has occurred, nutritional rehabilitation, and we have to manage the complications. WHO recommends daily iron folic acid for pregnancy, intermittent iron in high risk groups, fortification of wards, deworming, anemia surveillance, and health system monitoring and evaluation includes iron stock and coverage tracking. These are the indicators for monitoring and evaluation and follow up or screening. We have to see the prevalence of anemia, anemia region of hemoglobin, percentage of the people receiving iron folic acid, facility stock out rates, and school screening coverage. So again, these are the WHO recommendations as discussed before. We have to give daily iron folic acid in pregnancy. Intermittent iron should be given to the high risk groups, deworming of children and adolescents in the high burden areas, and we have to promote and regulate food fortification standards. Toxicity of iron can cause the symptoms of iron overload, gastrointestinal irritation, accidental pediatric poisoning risk. This can cause iron toxicity. This is the share of the population with anemia in high risk groups. The data is taken from, this is the data from 2019 from the website of WHO. So you can see that they have divided the data in different regions of the world. In the low income countries, 60% children are anemic, and 43% of the pregnant women are anemic. Women of reproductive age, 37%. The low middle income countries, and Pakistan is one of these countries. So here the 51% of children are anemic, 43% again the percentage is same, and 43% in the reproductive age group. The upper and middle income countries, the percentage has reduced in children to 24%, in pregnant women to 23%, and women of reproductive age to 19%. And in high income countries, the percentage is further reduced. In children, it's 14%, pregnant women 17%, and women of reproductive age 15%. So there is a large decrease in the percentages of anemia in the high income countries, starting from low income countries. So this is again the depiction of the percentage of anemia in pregnant women versus children. And the data is again from 2019 from the WHO website. So you can see Pakistan is, although is not there in this graph, uh, but the Asian countries fall midway around the 40% range of 40%, both in the children and in the pregnant women. Like we have our neighboring country Afghanistan, you can see the anemia percentage in children is around 43-45%, and in pregnant women the percentage is around 35%. So now we come to iodine. Iodine is essential for T3T4 synthesis, and its deficiency results in the spectrum of iodine deficiency disorders, IDDs. Iodine deficiency is the leading cause of preventable mental retardation. Flood-prone regions and iodine-poor soil regions are prone to iodine deficiency, and it's endemic in the mountainous regions. The sources of iodine are majorly iodized salt, and the natural foods include seafood, fish, dairy, eggs, and iodized oil is also used in the endemic regions. These are the WHO recommended nutrient intake for iodine: 120 microgram per day for children aged 6 to 12 years, and 150 microgram for adolescents and adults, and its double is to 50 microgram per day for pregnant and lactating women. So the major functions of iodine are metabolic regulation, somatic growth, organ development, and critical role in fetal and early childhood brain development. So the deficiency of iodine has a range of clinical features from goiter, hypothyroidism, which includes lethargy, cold intolerance, stunting, developmental delay, cretinism, miscarriages, stillbirth, and low birth weight. Diagnosis of iodine deficiency includes median 24-hour iodine urine. This is the mainstay of the confirmation of iodine deficiency. Then comes the thyroid function test, 24-hour radioactive iodine uptake, and a biopsy can be done, which will show hypoplasia. We have to manage iodine by giving iodized salt or oil in the endemic areas. The dose will be 200 to 400 milligram. And iodized oral doses can be given. The single dose and it lasts for 6 to 12 months. Levothyroxine can be given in the hypothyroidism. So now we come to the four levels of prevention of iodine deficiency. At the primordial level, we have to prevent the risk factors. So we have the goal to promote iodized salt use, public awareness, supportive policies. For primary prevention, we goal for the prevention of that deficiency. So um, um, we can go for universal salt iodization, iodine supplementations, and salt monitoring. Secondary prevention involves the early detection and control, which includes screening for goiter. We have to test for urinary iodine, supplement high-risk groups. The tertiary prevention level involves the limitation of complications. So we will treat hypothyroidism, rehabilitate the affected children. So the public health programs working for iodine deficiency are universal salt iodization monitoring, salt iodine enforcement, periodic UIC surveys, the urine levels, and the community information, education, and communication. This is a technique for health education on iodized salt. These are the indicators which can be used when we are doing the screening or we are doing the monitoring and evaluation of the iodization programs. So again, the WHO recommendations we have already discussed them. This is the program by WHO, Universal Salt Iodization and Sodium Intake Reduction, to provide a compatible, cost-effective strategies of public health, great public health benefit. This is a share of households consuming iodized salt. The data is from 2020, again from the website of UNICEF and World Bank. All right. You can see the darker the region is, the more households in that country are consuming iodized salt. But unfortunately, on their website, the data from Pakistan is not available. This is the data from uh, the annual report from Iodine Global Network, and you can see that the pink color shows that there is insufficiency in the global iodine status in the school age children. Green color shows the adequate status of use of iodine, and gray color shows excessive use, and it's shown by only one or two countries. But the good thing is that Pakistan is in the green color, so there is adequate uh, uh, global status in school age children. All right, this is the percentage of households consuming salt with iodine. The data from it is from 2021, and Pakistan has a percentage of 79.6%. So globally, the percentage was 89%, and in Pakistan, it's the 79.6%. Um, so this is the as I told previously, salt hybridization program. So this is the time frame of the timeline of that program, that it was launched in the 1980s, and then it went from many of the stages, and then in latest is into 2013, and there was phasing out of the free donations of the iodine, but establishment of a revolving fund was created to manage the distribution of it on no profit no loss basis. So now we come to fluoride. This is the trace element for dental and skeletal health. Both efficiency and excess carry public health importance. All right. So the sources of fluoride are drinking water, that is a major source, fluoridated toothpaste, seafood, fish, supplementation can be used where water fluoride is low. The daily requirements are 3 to 4 milligram per day in adults. Optimal community water level is 0.7 to 1.2, and children supplements includes the dose of 0.25 to 1 milligram per day depending on the age and water level. So the major functions of fluoride is to strengthen enamel, prevent caries, and support bone mineralization. The clinical deficiency um, symptoms include dental caries, early tooth decay, and elevated DMFT. DMFT index is used. We count the number of decayed, missing, and filled teeth. All right. The diagnosis of fluoride deficiency is made on the basis of the dental examination, water fluoride estimation, and again DMFT index tracking is done in school surveillance cohorts. So children in low fluoride areas are given 0.25 to 1 milligram per day oral fluoride supplements, and topical fluoride varnish and fluoridated toothpaste are given to the community or the school. So the prevention of fluoride includes the primary prevention, which involves community water fluoridation. The fluoridated toothpaste should be used. A secondary prevention involves the school dental screening and DMFT surveillance. And tertiary prevention involves dental restorations, cavity treatment, and complication management. So WHO recommend to support the community water fluoridation where feasible, to promote the fluoridated toothpaste and ensure safe fluoride concentrations in the community water. These indicators can be used for the fluoridation programs, DMFT index, school screening coverage, and water fluoride levels. Toxicity symptoms are dental fluorosis and skeletal fluorosis, the two major domains. All right, now we come to the recent updates. This is the article published in for the regional influences on nutritional iodine status of pregnant women in Pakistan. So they concluded that rural-urban disparities were observed only in socioeconomically disadvantaged districts, and these disparities limit the effectiveness of the IDD prevention program in rural areas in Pakistan. So the implementation of the mandatory salt iodization requires improvement, and program effectiveness should be continuously monitored. Then this is the article published in 2024. The topic is artificial intelligence applications to measure food and nutrient intakes. This was a scoping review, and the findings from this review suggest that AI has transformative potential for dietary assessment at both the individual and population levels, supporting precision nutrition and chronic disease management. Future research should focus on enhancing the robustness of AI models across diverse dietary contexts and integrating biological sensors for a holistic dietary assessment approach. So the conclusion of this presentation is that micronutrient deficiencies are preventable public health problems requiring integrated nutrition, surveillance, policy enforcement, and information education communication strategies for equitable population impact. Now we come to the MCQs. The first question is, a 28-year-old woman on long-term PPI therapy presents with muscle cramps and her ECG shows prolonged QT. Her potassium remains despite replacement. What is the most appropriate next step? Option A, give IV calcium gluconate. Option B, start oral iron 120 milligram per day. Option C, administer IV magnesium sulfate 2 gram over 10 to 15 minutes. Option D, give oral iodine 400 milligrams stat. Option E, start mebendazole for 3 months.
A.
Option C is the correct answer. As we said that in case of cardiac involvement, it's the emergency and the dose will be 2 gram and we will give this dose over 10 to 15 minutes. So cardiac involvement is emergency. All right, now we come to question number 2. A 6-year-old child from a mountainous region shows poor school performance and a visible neck swelling. Median urinary iodine in his community is 80 microgram per liter. Which public health intervention should be prioritized? Option A, fluoride supplementation, 1 milligram per day. Option B, universal salt iodization, 20 to 40 ppm. Option C, magnesium oxide, 300 milligram per day. Option D, daily zinc supplementation. And option E, iron sucrose infusion.
B.
Yes, option B is the right answer. Question number 3. A pregnant woman has HB 8.9, ferritin 8 microgram, and complains of craving mud, that is pica. What is the correct WHO aligned treatment? Option A, elemental iron 3 milligram per kg per day for 3 months. Option B, iron 60 milligram and folic acid 400 microgram daily for 3 months. Option C, IV magnesium sulfate 1 gram over 1 hour, or oral iodine 200 milligram single dose, or fluoride varnish weekly.
B.
B.
Yes, B is the right answer. In case of pregnancy, we have to go for IFA, that is iron folic acid both. Sorry. Question number 4. A 10-year-old child lives in a low fluoride area where water level is 0.4 ppm and has multiple decayed teeth. Which prevention level and intervention is this? Um, I'm sorry, it has
C.
skipped. All right, we move to the next question. Question number 5. A man at age 2-year-old admitted with diarrhea develops tremors and seizures. Labs show magnesium 1.2 milligram per deciliter, calcium 7.8 milligram per deciliter, and potassium is 2.9 millimole per liter. What should be part of the immediate management? Option number A, correct magnesium only with oral magnesium 80 milligram per day. And option B is give IV magnesium sulfate 1 to 2 gram over 1 hour and correct calcium and potassium simultaneously. Option C, start oral iodine 250 microgram. Option D, apply topical fluoride only. Option E, give 60 milligram elemental iron with 400 microgram folic acid.
B.
B.
Yes, B is the right answer. Question number 6 is a public health resident is monitoring an IDD control program. Which indicator best reflects population iodine status? Option A, transferrin saturation. Option B, median urinary iodine concentration. Option C, MUAC measurement. Option D, serum magnesium. And option E is serum, blood glucose.
B.
B.
Yes, B is the right answer. Question number 7, a 30-year-old ICU patient develops hypotension and respiratory depression after electrolyte correction. Which toxicity should be suspected? Option A, iron overload. Option B, iodine-induced hyperthyroidism. Option C, skeletal fluorosis. Option D, hypermagnesemia. And option E, levothyroxine toxicity.
D.
Yes, option D is the right answer. In ICU patients, magnesium should be there in the mind. All right, question number 8. A community has high anemia prevalence in women and children. The health department starts HP screening in schools and antenatal clinics. This represents option A, primary prevention, B, secondary, C, tertiary, D, external evaluation, and E, participation monitoring only.
A.
Secondary.
Yes, screening is part of secondary prevention. Question number 9 is a policy is introduced to regulate iodization of household salt at 30 ppm and ensure community water fluoride 0.7 to 1.2 ppm. This falls under option A, secondary prevention with clinical diagnosis. Option B, policy legislation and with that is primary prevention. And option C, tertiary management only. Option D, internal evaluation strategy. Option E, individual behavior change only.
B.
Yes, B is the
B.
right. Uh, all right. There is a policy which is introduced, and the management or regulation of these levels is primary prevention. All right. Now we come to the last question. 10. District Health Department wants to assess early detection efforts for micronutrient deficiencies. They track hemoglobin screening coverage in schools, median urinary iodine from sentinel sites, and DMFT index during annual surveys. This approach best represents option A, primary prevention. Option B, secondary prevention. Option C, tertiary prevention. D, internal evaluation. And E, external audit.
B.
B.
Yes, again, screening is part of secondary prevention. This is the MCQ's key. This is a YouTube channel of Institute of Public Health where this presentation will be uploaded. And thank you so much.
Thank you so much. It was a very informative and good
Thank you so
presentation.
much.